the field of my research on my publication. I have a small conflict of interest. I'm working part-time, only 20% by a Swiss medtech company, a small Swiss medtech company. We develop a POCT with a new nanofluidic technology to test biomarker in less than 10 minutes, even 5 minutes, able to test CRP, ferritin, D-dimer, PSP, and so on, and so on. All biomarker you want could be tested in that machine in less than 5 to 10 minutes. Well, my presentation will be like this. First of all, I'm going to speak about the sepsis definition diagnosis, just a small remember to speak about all the same thing: biomarker, early diagnosis, current research, ideal criteria for an early sepsis biomarker. I'm going to give you an example and then the conclusion. Sepsis definition, I'm sure you know it, of course, based on the last surviving sepsis campaign of October 2021. To have sepsis, we must have an infection plus inflammation plus an organ dysfunction. And for the diagnosis of infection, we are not using biomarker. No biomarker are recommended. Even PCT is not recommended, but this is a clinical evaluation only that is the best practice statement. And for inflammation, this is quite the same thing because we have to use clinical score, the CIS92 score, while there is two biomarker in this score, leukocyte and PaCO2, but not CRP. And for organ dysfunction, once again, there is no biomarker. There is, once again, clinical score like Muse, NEWS, or SOFA score. And even lactate is not recommended for the diagnosis of sepsis in 2021, based on the guidelines, so still in 2023. So biomarker, if I told you there is no reason, no biomarker recommended at the moment, no PCT, no CRP, no lactate. But the problem is that the clinical evaluation, as I showed you before, to have the diagnostic of sepsis has a bad specificity, and you know it, that based on that clinical score, we are giving too much antibiotics. Even 70% of the times, we were using too much antibiotics because there is, after that, no confirmation of infection if we decide to start antibiotic only based on clinical score. And in Switzerland, I don't know if it is the same case in Sweden, but medical doctor, we have did a small survey here. Medical doctor are using more biomarkers than clinical score. Quite 100% of my colleagues are using biomarker, but only less than half of my colleagues are using clinical score. So based on this observation, we think maybe biomarker could be useful. And the first question at that time is, do you think we need one biomarker for sepsis, or maybe 2 or 3 or 4? I think we need maybe a biomarker for infection, a biomarker for inflammation, a biomarker for organ dysfunction, or maybe a biomarker for the overall for sepsis. But the first question is, how many biomarkers do you think we need for the diagnosis of sepsis? Maybe 4. And if we are using biomarker, what will be the purpose of this biomarker? And there is a study published in 2009 in Critical Care Medicine Journal, saying that the biomarker for sepsis must have 5 purposes. The first one will be screening. Screening means early pre-symptomatic diagnosis of sepsis. To screen patient, and it will be for patient hospitalized, of course, to screen patient to be sure they are not going to develop sepsis. Another purpose is diagnostic at time of clinical suspicion to confirm or not sepsis at that time. To monitor especially the treatment efficacy and to decide for the de-escalation of antibiotics. For risk stratification to predict evolution, and for surrogate endpoint to predict outcome and mortality. In my point of view as a clinician, the 2 last items, risk stratification and surrogate endpoint, is not so useful in my daily practice because I'm not going to stop treatment because I think because the biomarker is high, that the patient is going to die in the next 28 days. So there is, in my point of view, 3 more important items than the two last. But as I show you there is 5 different situations. As I told you before, there is maybe 4 different parameters for sepsis. So I present you this table showing these 5 conditions: screening, diagnosis, monitoring, and risk stratification, and the 4 condition, infection, inflammation. So maybe I'm not sure that one biomarker is going to fill all the box, the 20 use and 20 different possibilities. And maybe we need 20 different biomarker. I don't know. This is a question. I am quite sure that one will not going to fit all, and 20 maybe it will be too complex in the daily practice. What is early diagnosis? Because it is the title of my presentation, I will say early, I told you already, means really pre-symptomatic diagnosis of nosocomial sepsis. This is for patients at risk of nosocomial infection in the hospital. And this is to detect, probably by daily monitoring, to detect even before symptoms, patients who are going to develop sepsis. So for that kind of test of biomarker for early, we need a test with a very good sensibility and a very good positive predictive value. I compared early screening by quick diagnosis. Quick diagnosis, it means a time of clinical suspicion. And at time of clinical suspicion, we all know we have 45 to 60 minutes to decide to start or not antibiotic. So we need a test at that time to quickly decide or to confirm there is or not a sepsis, and to give or not to give antibiotics. This is a question. And of course, we have to give as less as antibiotic as possible based on the problem of antimicrobial resistance. And for this test, we need a biomarker with a very good specificity this time, not sensitivity, but specificity, and a very good negative predictive value to help us, the clinician, not to start antibiotics. So where are the current research at that time? There is a study published in 2010 showing that there is already 178 different biomarker study in the literature. 10 years later, there was 258 different sepsis biomarker. And of course, there is classical biomarker like CRP, PCT, lactate, some new classical biomarker like interleukin, presepsin, pancreatic stone protein, and so on. And it's interesting to know that in these 258 sepsis biomarkers, there is 9 biomarkers that are better than CRP and PCT, but they are not so well known. Mainly probably because there is not a lot of study on that biomarker. And for example, the majority of these 258 sepsis marker had 31% of this biomarker had only one study. But the literature is huge, and this is a small PubMed research done last month in April, showing that there is more than 12,000 publications about sepsis biomarker till 1972. And for example, only that year in April, there was already about 300 studies on biomarker. So as I told you before, we need maybe a biomarker for infection, biomarker for inflammation, biomarker for organ dysfunction, or maybe a biomarker for sepsis. So where are the current research on biomarker of infection? As I told you, PCT is not recommended because the negative predictive value is not very good. Even PCT is very low. Presepsin is a new biomarker, more specific for gram-negative bacteria. Neutrophil to lymphocyte ratio and monocyte dispersion width is other two biomarker of infection, but they are pathogen agnostic. It means these biomarkers are not able to make the difference between bacteria and virus, so it is not so useful to help us to decide or not to start antibiotic. For presepsin, there is quite a lot of studies, but there was even a meta-analysis showing that the negative predictive value is not so good. So maybe this biomarker is not so useful to help us, or not better than PCT to help us to start or not antibiotics and to be sure there is a bacterial infection, because this biomarker is maybe more specific only for gram-negative bacteria. And there is some new metagenomics and transcriptomics way of doing. I'm not going in details for this technique because this is quite complex, this is quite expensive, and at the moment this is quite low, so not useful in daily clinical practice. What is new for infection? And you are infectiologist, so you are much better than me, but you know that there is new technology to have a result of blood culture and much more quickly and faster. And this is useful to identify the bacteria, but it takes 5 to 6 hours. And there is new technology as well to get the antibiogram in 5 to 6 hours. So of course, it shortens the identification of the pathogen, but it doesn't help us to decide to start or not antibiotic. Maybe it could help us to stop antibiotics, but it doesn't help us to start antibiotics. For inflammation, CRP is very, very good marker of inflammation. But as you know, inflammation is not specific of sepsis or infection. So because this biomarker is not specific, it is not going to help us to decide or not to start antibiotic, for example. For organ dysfunctions, there is other new biomarker like the proadrenomedulin biomarker, showing it works very, very well for organ dysfunction. But organ dysfunction is like inflammation. It is not specific of inflammation. For example, this new biomarker is increasing as well in condition of cardiogenic shock. The question is now, I showed you before, there is 258 studies, different biomarker, not studies, even more, but the 258 different biomarker. And there is a lot of research at the moment on biomarker of sepsis for in different setting in the pathophysiology of sepsis. And the list is very, very long. I of course, no time to go too much in details for all these kind of biomarker, acute phase protein, damage-associated molecular patterns, cytokine, and so on, hormone receptor, hormone peptides, and so on, and so on. So there is a lot of different biomarker studying at the moment for sepsis, something like an overall biomarker for infection, inflammation, and organ dysfunction. Of course, you know, sepsis is very complex, and it will be difficult maybe to find only one biomarker in this complex pathophysiology to diagnose sepsis. So there is a lot of biomarker. So maybe we have to find criteria, an ideal criteria for an early sepsis biomarker. And in 2010, a group published a study for ideal criteria for sepsis biomarker. And this criteria was ASSURE, acronym was ASSURE criteria. ASSURE means affordable, not too expensive, and for sure less than the price of antibiotics, or maybe the same price of the antibiotic, because this biomarker is going to help us to decide or not to give antibiotics, so the price might be not bigger than the price of antibiotics. Sensitive, the biomarker must be sensitive with a very good positive predictive value, and it will be really, really useful for the early pre-symptomatic diagnosis of nosocomial sepsis. Specific, of course, with a good negative predictive value for the quick diagnostic to rule out or not sepsis. User-friendly, for sure. I think POCT, point-of-care testing, will be the best way. Rapid, of course, less than 45 to 60 minutes for sure, to help us to decide or not to start antibiotics. Equipment-free, I think this objective will be quite difficult to obtain, but it will be, I will say, the equipment as simple as possible. And two other criteria are not belonging to the ASU criteria, but for pediatrics, we need small sample of blood. So that's why could be done, must be done with a small sample of blood, and certified. Of course, and belongs these 258 biomarker, only, I don't know exactly, but 5 to 6 or maybe 7 are certified, CE certified, FDA certified. And of course, this is really important for our daily practice and for reimbursement as well. So we published 2 months ago a checklist showing which criteria an ideal biomarker must fulfill to be useful in our daily practice. And now I'm going to give you an example of PSP and CRP. Maybe you don't know what is PSP. PSP is pancreatic stone protein, and this is a damage-associated molecular patterns. There is already more than 600 peer-reviewed studies on PSP, on 46 peer-reviewed study on PSP and sepsis, more than 4,000 patients. There is already one prospective multicentric study, a European prospective multicentric study published in 2021, the Critical Care Journal. There was a meta-analysis already, literature review and so on of PSP is certified in Europe, in Australia, in Switzerland. and it is expected by the FDA in the US at the end of this year. And the test could be done in less than 7 minutes at the bedside. And we need 50 microliters of whole blood, even capillary blood, to do the test. So you can see that with the first presentation, that PSP fulfilled quite most of the ASHRAE criteria. And PSP is useful for the early sepsis diagnosis. This was highlighted by a study published in 2020 by a team of the University Hospital of Zurich in a burn center, and there was only burn patient, 90 burn patient. Of course, you know that burn patients are at high risk of nosocomial infection, and they test biomarker every day to that patient. And for CRP, you can see that CRP is increasing. In green, you have no infection. In blue, you have infection. In orange, sepsis, and in red, septic shock. And you can see that CRP was increasing after the event. And there is no correlation with leukocyte. And with PCT, we can see that PCT was increasing at the time of sepsis, so at the time of clinical suspicion, and PSP was increasing already 3 days before. And so this PSP could be used and as an alert signal. And based on that study, the multi-centric study was done. So 14 centers all over Europe, in Switzerland, Italy, UK, and France. 250 patients admitted in the ICU for different reasons. And this study shows that PSP is increasing already days before, even 5 days before. And you can see here on the left that patient without sepsis or septic shock in blue, PSP maintains low, but patients who are going to develop sepsis have higher PSP value. And you can see that the standard deviation are not overlapping. And this is not the case with PCT, with huge standard deviation. It is quite possible with CRP to do that, but CRP is increasing at time of clinical suspicion and not already before. And this was highlighted in a quite complex cases we published last year. This is a case report of a man. I'm not going too much in details in this case report, but it was just to show you, it was a man with a postoperative peritonitis of a complication of abdominal surgery, presenting a lot of sepsis and infection, and we have to open his belly many times, and the patient was admitted in profound septic shock, and we test daily PSP. I'm not going too much in detail, but all the times that PSP was increasing, something happened, and we go back to the patient, and all the time it was for good purpose. So this is a way to highlight you this daily monitoring of PSP help us, the clinicians, the intensive care physician like me, to detect in advance and even before clinical symptoms sepsis. That's why we propose that kind of graph and value on the daily monitoring of PSP. And when PSP is going to increase, we have to start exams and maybe already antibiotics. So it was the use of PSP for early diagnosis, and for the quick diagnosis, it means at time of clinical suspicion. Studies show that the combination of PSP and CRP has the best accuracy, with around the curve of 90%, with good sensibility and specificity, and the result is better than PSP alone, CRP, PCT, and the combination of PCT, CRP, and PSP is not better. So PSP and CRP has the best accuracy to detect and to confirm sepsis at time of clinical suspicion. That's why we propose to introduce this biomarker in the sepsis 3 definition beside the clinical evaluation, not to replace the clinical evaluation, but beside. And we propose to use biomarker to quickly rule out or rule in sepsis at time of clinical suspicion, or to decide maybe not to start antibiotics. And this is really useful, as I told you before, because of antimicrobial resistance for sure. Just to summarize, PSP and CRP, early PSP could help us to detect sepsis 3 to 5 days before sepsis. The combination of PSP and CRP help us to decide or not to start antibiotics at time of clinical suspicion. And there is, as I told you already, 46 studies, and there is more than 20 international studies ongoing. As I told you before, we can show or think that PSP and CRP combination fulfill the ideal criteria and the assure criteria for biomarker for sepsis. Conclusion, if I show you the table I show you in the beginning of my presentation with the 20 possibilities, we think that biomarker for inflammation or organ dysfunction is not so useful. Biomarker for risk stratification, a surrogate endpoint, is not so beautiful in my daily practice. So from the beginning with 20 maybe biomarker, I think only 6 could be useful. 6 for screening infection, for diagnose infection and monitor infection. And PCT is very well known to monitor infection and to help us for the de-escalation of antibiotics. And for sepsis, for screening, diagnosis, and monitoring. And we propose, based on the example of the already study published, to use PSP for screening and PSP and CRP for diagnosis and PCT for monitoring. So for sure, combination of biomarker must be useful, but hopefully not 20 biomarker, but maybe 3 biomarker could be enough. So my conclusion, my take-home message, no biomarker are currently recommended in the international guidelines, as I showed you at the beginning. Future research must specify the intended of use for the biomarker, maybe 20, but I hope there will be less biomarker at the end. For studies, we have to apply standardized protocol to answer clinical questions because most of the study, unfortunately, doesn't answer clinical question. For the next study, for new biomarker, we don't have to compare the new biomarker with old biomarker because the old biomarker are not validated. So study must not compare biomarker X with CRP, PCT, or like that. Biomarker must answer clinical question. All future biomarker of sepsis will have to be assured and certified, of course. And I think the answer at the end will be a combination of biomarker and maybe a clinical pretest probability score must be useful and will be probably the current missing tool. And maybe all this could be integrated into a machine learning system we will see in the next future. But for sure, the test must be done quickly to get the answer. So thank you very much for your attention. I hope it was clear. Of course, I'm open to answer question.